All right, let's jump right in today and talk about cardiogenic shock.
Ooh,
I mean, this is a condition that I think keeps a lot of us up at night, right?
definitely.
We always talk about the stats, 30 to 50% mortality either in hospital or within 30 days.
Right.
And, even with all the advances that we've made in medicine, it's still just a really tough battle.
Yeah, it really is. And I think one of the things that's really interesting is how the landscape of cardiogenic shock is shifting,
Oh, yeah. How so?
Historically, we've always thought about cardiogenic shock being tied to acute MI.
Right. Acute myocardial infarction.
Exactly. But now we're seeing acute heart failure as a more frequent culprit. So
that's a really important point for all of us as, providers on the front lines. What does that mean for us in terms of how we're approaching these patients?
yeah, I think it means we really need to broaden our thinking.
Yeah.
When someone comes in with signs of shock, we can't just get tunnel vision on that AMI. We need to think about acute heart failure and really have that high on our differential, because the faster we intervene, the better chance we have at preventing that whole cascade of organ failure that can happen.
Right, because at the core of it, cardiogenic shock isn't just a heart problem, right? It kind of sends the whole system into chaos.
Exactly. Think about it. The heart can't pump effectively. So what happens? Blood flow to the tissues is compromised.
Right.
Less oxygen is getting to all the vital organs.
Right.
And so it leads to multi-system dysfunction.
Yeah.
We're talking respiratory, renal, hepatic, even neurological systems all taking a hit.
It's kind of like that figure, I think it was figure 1 in the article that we're looking at today from the Journal of the American Heart Association.
Mm-hmm.
The need for a cardiogenic shock team collaborative.
Mm-hmm.
It really drives home that domino effect that happens.
It does. And because of that multi-system nature of cardiogenic shock, we're seeing more and more that we need those non-cardiac organ support therapies for these patients. These are really critically ill patients.
Yeah.
The article mentions a median ICU stay of 5 to 15 days, so that's a long time.
Wow.
And then if you look at Table 1, you see just the extensive list of resources that are needed to manage these patients.
Right. And so, given this whole complexity of cardiogenic shock, it's no surprise that people are pushing for this more collaborative approach.
Yeah.
These specialized cardiogenic shock teams. So why is this becoming, why is this gaining so much traction?
Yeah, I think for a few reasons. First off, there's the time factor.
Right.
Cardiogenic shock is a race against the clock.
Absolutely. Every minute counts.
Every minute counts. So if you have a dedicated team, you can really streamline that decision-making process, shave off those precious minutes. That could really mean the difference.
I can just imagine how much faster things can get done when you have a team that's all on the same page and coordinated.
Right. And then there's also the need for that multidisciplinary expertise. If you look at Figure 2 in the article, it shows all the different specialties that can be involved.
Yeah.
Cardiology, critical care, surgery, nephrology, even palliative care sometimes. So having a dedicated team brings all of that knowledge and experience together in one place.
Right. So it's kind of like you're assembling a rapid response team of experts that are just like laser focused on cardiogenic shock.
Exactly. And then finally, we can't forget about standardization.
Right.
Right now, there's a lot of variation in how cardiogenic shock is managed across different hospitals.
Yeah, that makes sense.
So teams can help bridge that gap and make sure that everyone's getting the best possible evidence-based care.
Yeah, so no matter where you end up, every patient has the potential to get, the same high-quality care.
Exactly. We've seen this with heart teams for structural heart disease.
Right.
That's really gained widespread acceptance and led to some major improvements. So it makes sense to apply that same concept here.
Okay, so let's get into some real-world examples. The article highlights 3 institutions that have successfully implemented these cardiogenic shock teams. And I'm really interested to hear, what we can learn from their experiences.
Yeah, me too.
So why don't we start with Innova Heart and Vascular. What did they do differently?
Okay, so picture this. You're on call and a patient comes in with signs of shock, Well, with the Innova model, there's a standardized evaluation process in place.
Okay.
Any patient that they even suspect of having cardiogenic shock is immediately assessed by the team.
Okay.
And this early identification is key because it allows for rapid intervention.
Right. You're catching them before they really start to decline too much.
Right. And they're also really big on minimizing the use of vasopressors.
Interesting.
We know those can be a double-edged sword.
Right.
They can help maintain blood pressure, but they also constrict blood vessels, which could actually worsen organ perfusion in someone who's already struggling.
So it's all about striking that right balance.
Yeah. Exactly. And then what about mechanical circulatory support? Was that part of their approach?
Oh, yeah, for sure. So MCS.
Yeah, they used it to help the heart pump more effectively, but the key was tailoring the type and timing of MCS to each patient's specific hemodynamic needs.
So it's not a one-size-fits-all approach.
No, not at all. It's about individualizing the care based on their presentation and how they're responding.
And what about, anything else that they were really focusing on?
Yeah, they paid close attention to best practices for vascular access and closure. Their approach really highlights the need for a comprehensive and meticulous approach to care for these patients.
And the results speak for themselves, right?
Yeah.
I mean, their 30-day survival rates jumped to over 70%.
It's pretty remarkable.
It is. Yeah, and for our listeners who are interested, if you want to see a visual breakdown of Innova's approach, Figure 3 in the article does a great job of summarizing everything.
Yeah, I like that figure.
Yeah. So we've got Innova focusing on early identification, judicious use of those vasopressors, and then tailored MCS.
Yeah.
What about the University of Utah? What stands out about their program?
So the University of Utah took a really pragmatic approach, and, they serve a pretty large geographic area.
Right.
So they realized that activating the team needed to be as seamless as possible.
Yeah, you want to minimize any delays.
Exactly. So they developed a simple activation algorithm that literally any clinician can use.
Nice. So really low threshold for activation. If you're even thinking about it, just call the team.
Yep. And once the team's activated, they don't waste any time.
No.
They immediately initiate empiric medical therapy,
Right.
and they perform a right heart cath to help guide their next steps.
Wow, so they're moving quickly.
They are, and then they'll escalate to MCS if they need to,
Right.
but only if specific criteria are met.
Okay.
But here's what's really interesting. Once they do that initial triage, they actually emphasize primary team autonomy.
So the cardiogenic shock team isn't like, micromanaging every decision.
No, they trust the cardiovascular ICU team to kind of take the lead after that initial assessment.
I like that.
And their data actually shows that it doesn't lead to any delays or conflicts. It's just about empowering the primary team.
So that balance between collaboration and autonomy.
Yeah, exactly. And another key takeaway they had was the importance of including the cardiovascular ICU nurses.
Right. The nurses are such an important part of the team.
Oh, absolutely.
They're the ones that are, at the bedside, they see those subtle changes in the patient's condition.
Yep. They bring such a valuable perspective.
And, because they cover such a large geographic area,
Right.
they're even looking into the potential of doing this virtually, like a virtual collaborative shock team.
Yeah, using telehealth to bring those specialists together.
Oh, wow. That's innovative.
It could be a game changer for, more rural areas.
Right, where they might not have access to a big center.
Yeah.
Okay, so we've got Innova, we've got the University of Utah. Let's wrap up with our final success story, the University of Ottawa.
No. Okay.
What lessons did they learn?
The University of Ottawa really emphasizes adaptation and flexibility.
Oh, okay.
They stress that any of these published management algorithms, they need to be tailored to the local resources and systems.
Yeah, what works in, a big academic center might not work in a small community hospital.
Exactly. And they also highlight the importance of starting small and building gradually.
Yeah, don't try to do everything at once.
Right. Start with a few key elements.
Right.
Make sure those are running smoothly, and then expand from there.
It's like, always got to be looking for those kinks in the system and ironing things out as you go.
Exactly. And of course, they reinforce the theme that we've been seeing throughout, the importance of multidisciplinary expertise.
Right.
And collective input in managing these complex cases.
It's all about the right people coming together and working toward that shared goal. All right, so we've seen how these individual institutions are achieving some really great results with their cardiogenic shock teams. But what if we could take this even a step further?
Oh, yeah. How so?
Imagine a nationwide network of, CS experts all collaborating, sharing knowledge, and pushing the field forward.
Ooh, I like that idea. And it might not be as far-fetched as you think.
Really?
Yeah, because we already have a blueprint for success.
Hmm.
The Pulmonary Embolism Response Team, or PERT.
PERT is incredible. I've always been so impressed with the work that they've done.
Yeah.
They've really changed the game in terms of PE care.
For sure, and I think their experience provides valuable lessons for how we can build something similar for cardiogenic shock.
So let's talk about that. What are some of the key things that make this model so transferable?
Yeah, right.
What are the similarities between PE and CS that make it a good fit?
Yeah, I think the biggest one is that both conditions are super time sensitive.
Right.
You know, the faster you diagnose and intervene, the better the outcome's going to be for the patient.
Makes sense.
And both conditions benefit from that multidisciplinary approach.
Mm-hmm.
It's not just one specialty, calling the shots. It's about bringing everyone together and creating that comprehensive care plan.
And PERT has shown that that really can work. They've managed to standardize PE management, which used to be all over the place.
Yeah.
And that standardization has led to some really impressive outcomes for patients.
Right, and their impact extends beyond treatment, too.
Oh, how so?
Well, they've really fostered research and innovation in PE.
Oh, that's great.
Pushing the boundaries of what we know and what we can do. And then they've also created this amazing global network of experts.
Right, a whole community that's dedicated to tackling PE.
Exactly, it's pretty inspiring.
So how do we translate that to cardiogenic shock? What would a cardiogenic shock team collaborative actually look like?
Well, imagine a network of specialists from all across the country working together to develop best practices, conduct research, standardize treatment approaches for cardiogenic shock.
So it's like a national think tank for cardiogenic shock.
Exactly.
I love that. But, big ideas need fuel.
Yeah.
What kind of resources and partnerships would we need to get this off the ground?
Well, I think we'd need buy-in from a lot of different stakeholders.
Yeah, like who?
Hospitals, professional societies, research institutions, even industry partners. Anyone who has a stake in improving outcomes for these patients.
So it's a big lift, but it seems like the potential payoff is huge.
It really is. I mean, think about what we could achieve with this kind of collaborative effort,
Yeah.
We could develop national educational programs for providers, establish centers of excellence for cardiogenic shock care, even advocate for policies that could improve access to treatment and resources.
So it's not just about treating patients, it's really about transforming the whole system of care for this condition.
Exactly.
And we have this model for success in PERT. How do we take that and translate it into a concrete plan?
Right.
What are those first steps toward creating this cardiogenic shock team collaborative?
Well, I think the first step is raising awareness.
Okay.
We need to make sure that every healthcare provider out there understands just how urgent the need is for a new approach to cardiogenic shock care.
Yeah.
We talked about the numbers.
Yeah.
That mortality rate is still way too high.
Right.
We have to do better.
So spreading the word is that first step?
Yeah.
But obviously awareness alone isn't enough.
No.
What's next?
We need to start thinking about practical implementation.
Yeah.
Do we have a cardiogenic shock team in our hospital?
Why?
If not, how can we advocate for creating one?
Yeah.
And if we do have a team, how can we make it even more effective? How can we learn from the success stories that we've been talking about?
Yeah, how can we all contribute to this national collaborative?
Exactly.
So it's a call to action for everyone.
Absolutely. We have a responsibility to these patients, and we can make a difference if we work together. And, our listeners are a big part of that.
So what can our listeners do after listening to this? What can they do right now to be a part of this movement?
Well, for starters, you can start a conversation.
Okay.
Talk to your colleagues about what you've learned,
Right.
Explore the possibility of forming a team at your hospital.
Uh-huh.
Share the information from this episode.
Right.
Knowledge is power. And the more people we have on board, the faster we can move towards a better future for cardiogenic shock care.
It's about planting those seeds.
Yeah, and don't underestimate the power of your voice. Advocate for your patients. Advocate for better resources. Advocate for this collaborative.
Yeah.
Every voice matters.
This is powerful stuff. It feels like we're on the edge of a real paradigm shift here in how we approach cardiogenic shock.
I think so too, and I think this collaborative network could really be the catalyst for that.
I'm already thinking about how I can apply these ideas in my own practice.
That's great, and I encourage all our listeners to do the same. Start by having those conversations, explore the potential for a team at your institution. And remember, PERT is a great model to follow.
Yeah, they really demonstrate what's possible when we all come together.
Exactly. We have a real opportunity to transform care, and it starts with each of us taking action.
I love that message. It's so empowering.
It is. We can do this.
All right, so we've talked about the vision, this idea of a national cardiogenic shock team collaborative.
Right.
We've talked about the inspiration that we can draw from PERT. And we've talked about those first steps that we can take to turn this vision into reality.
Absolutely.
But now I think it's time to get even more specific and talk about the challenges and opportunities that you as a listener, in your own institution might face when it comes to implementing a cardiogenic shock team. All right, so one's talked about the vision, this idea of a national cardiogenic shock team collaborative.
Yeah.
We've talked about the inspiration that we can draw from PERT. And we've talked about those first steps that we can take to turn this vision into reality.
Absolutely.
But now I think it's time to get even more specific and talk about the challenges and opportunities that you, as a listener, in your own institution, might face when it comes to implementing a cardiogenic shock team. So let's start with the hurdles. What are some of the challenges that institutions might encounter when they're trying to build this kind of collaborative team?
Yeah, well, I think one of the biggest ones is buy-in.
Okay.
You need everyone on board, the cardiologists, the intensivists, the surgeons, the nurses, the administrators, everyone. And let's be real, not everyone is going to be immediately thrilled about this idea.
Yeah. I mean,
Right?
change can be tough, right? Especially in medicine. People get used to doing things a certain way, and it's hard to shift those patterns.
For sure. So you need strong leadership, you need clear communication, and you need a really compelling case for change.
Right. You got to show them why this is so important.
Exactly. And data speaks volumes.
Data is key.
So showcasing the potential benefits, those improved outcomes, reduced complications, maybe even cost savings, that can be really persuasive.
Yeah, I think sometimes it's not just about the data, though, right?
What do you mean?
It's also about appealing to people's hearts,
Yeah.
reminding everyone that this is ultimately about saving lives and improving patient care and, creating a better work environment for everyone.
Couldn't agree more. And, another thing that can be really helpful is involving key stakeholders from the get-go.
Oh, yeah. Get everyone at the table.
Exactly. Get input from the nurses, from the frontline providers, from the administrators.
Yeah.
Make sure that everyone feels heard and that their concerns are addressed.
It's about building a team, not just dictating from the top down.
Right.
So we've got buy-in. Let's say we've convinced everyone that this is a good idea. What about resources?
Ugh, resources. That's always the challenge, right?
It never goes away.
It never goes away, but, let's not get discouraged. We can get creative.
How so?
Well, maybe there are some existing resources that could be repurposed.
Okay.
Or maybe you could partner with another institution,
Yeah, share the costs.
Yeah, share costs, share expertise. Or, maybe you can make the case to the administrators that having a dedicated CS team could actually save money in the long run.
Oh, yeah, because you're preventing complications and you're shortening hospital stays.
Exactly. So it's a win-win.
So it's about making that strong business case as well as the clinical case.
Right.
Okay, so we've talked about some of the challenges. Let's talk about the flip side. What are the opportunities that institutions might see by embracing this team-based model?
Well, I think the biggest one is the impact on your patients.
Right. That's what it's all about.
We've seen how these dedicated teams can really improve survival rates and reduce those complications.
Yeah, those numbers are really impressive.
They are. And, those improved outcomes can have a ripple effect.
Well, how so?
Well, hospitals that are known for their expertise in this area, they're going to attract more patients.
Yeah.
They're going to build a stronger reputation.
Makes sense.
And they might even be able to attract more funding for research and education.
So it's kind of a virtuous cycle, right?
Exactly. Better care, better reputation, better resources, and ultimately, even better care.
I love that.
And then, we can't forget about the impact on the field as a whole.
Right.
If we create these collaborative networks, we can pool data from different institutions, we can conduct larger scale studies, and really accelerate research into new treatments and technologies.
So it's about breaking down those silos and really working together to move the field forward.
Exactly.
And I imagine this kind of collaboration can be really professionally rewarding too, right?
Oh, absolutely. You get to learn from colleagues in different specialties. You share perspectives, you expand your own skill set.
Yeah, it's all about creating that culture of continuous learning and collaboration.
Couldn't agree more.
This has been such an amazing discussion. I'm already starting to think about, how I can apply these ideas in my own practice.
That's great.
What's the one key takeaway that you want our listeners to walk away with?
I want them to remember that we have a chance to really change things here.
Yeah.
Cardiogenic shock is a tough condition, but we don't have to just accept the status quo.
Right.
By working together, by collaborating, by sharing our knowledge and resources, we can make a real difference for these patients.
It's a message of hope and possibility.
It is, and it's a call to action,
Yeah.
We need everyone to be a part of this movement. So start those conversations, explore the potential in your own institutions, and never underestimate the power of your voice and your dedication.
What really strikes me about this whole concept is that it's not just about the medicine. It's about something bigger.
Yeah. What do you mean?
It's about human connection.
Yeah.
It's about collaboration. It's about that belief that we can achieve more when we work together.
That's beautifully said. It's about that collective spirit of healthcare,
Yeah.
that shared commitment to easing suffering and improving lives. And you're right, that's something worth fighting for.
Well, on that inspiring note, I want to thank you for joining us on this journey into the world of cardiogenic shock teams.
It's been a pleasure.
And to our listeners, thank you for your dedication to these patients.
You guys are amazing.
And for everyone who wants to learn more, be sure to check out the article we've been discussing. Need for a Cardiogenic Shock Team Collaborative, promoting a team-based model of care to improve outcomes and identify best practices, from the Journal of the American Heart Association.
Yep, the link is in the show notes.
And to our incredible listeners, keep exploring, keep pushing boundaries, and never stop believing in the power of collaboration.
We'll be back next time with another fascinating topic, but until then, stay curious.
Disclaimer and bibliography in the description.